Gotta get used to this time change.
I didn't put the wrong PowerPoint in for this week. It's the Florida one under the digital.
Okay, let's try this again. So once again, this is a lot of material. It's a lot of information. So if we don't finish during lecture, we'll finish the first part of lab and then do the lab activities. So I'm actually going to sit this morning. So we're going to look at image histograms, talk about what that is, talk about automatic rescaling, some different contrast enhancement functions that you can do post-processing, what happens if the improper algorithm is used or the wrong lookup table, meaning you choose the wrong projection. Like say you're supposed to be doing a chest, but you have it on hand or foot, how that can affect the quality of your image. And look at some other image manipulation things that we can do in image management. So whether we're talking about CR or DR, after those photons have been converted into signal, then we can manipulate that for either while it's processing or what's used when it's being processed, meaning the algorithm that's used to determine the image histogram, again, choosing the correct projection that you're doing associates the correct lookup table with that exam, or the post-processing things that we can do after the image is popped up. So the things like adjusting the brightness and the contrast and maybe enhancing the contrast and those types of post-processing things. So image sampling is used in CR only. And so we talked a little bit about this last week when we were talking about sampling rate or sampling frequency. So the imaging plate is scanned. So you take the cassette or the IR, you use it with the patient, then you take it to a reader and you put it in the reader. And this is what the reader is doing. It has a laser in there and it's sampling, taking different data points throughout that. We talked about the image location and orientation being determined last week. You know, there's every pixel has a location, an XY coordinate location. The size of the signal is determined. So the size of the signal meaning at each data point that is sampled, and then a value is placed on each pixel. We talked about that last week. Based upon the amount of remnant radiation that's received, we call that quantization. So assigning each pixel a number that's associated with how much radiation actually interacted with that part of the IR. And then that value represents a shade of gray or a brightness level. And then a histogram is generated from that image data. So what exactly is a histogram? Well, it's a graphic representation of a data set. When we look at the histogram, and I have a picture on the next slide, the peaks and the valleys of the histogram represent the subject contrast. And the x-axis represents the pixel gray shade values, and the y represents the number of pixels with that value. So let's look here. So in other words, this is just a generic looking histogram of a typical chest x-ray. Down here, the values, however many values you have, which is determined by what? Matrix. What determines how many shades of gray you see in the image? Bit depth, right? Bit depth. How many shades of gray you see in the image is determined by the bit depth. So depending on the bit depth of the system, there may be 256 shades, right? That was 2 to the 8th. We talked about that when we were doing the ImageJ stuff. So let's say this is a 8-bit depth system. So values either 0 through 255 or 1 through 250, Yeah, 0 through 255 or 1 through 256. It depends on if the first value is assigned as 0 or not, would be on the x-axis. So these are what possible values are there in the image. And then on the y-axis is how many times do we see each one of those values in the image. So you may have a value of, for example, let's just say 10. How many times is 10 seen in that image? And that would be plotted on the y. So typically, histograms of certain projections are going to look very similar between yours, my image, your image, whatever. It's going to look very similar to this if you use the correct algorithm, meaning you choose chest when you're doing a chest and you don't choose hand when you're really doing a chest. It's going to change things. So it's going to typically look like this. This is an up close of that, okay? And so this is just showing you that if these are the values so these different shades in this histogram are supposed to represent the shades that are available in the image. Okay, so you can see we go from very, very bright to very, very dark, right? And so this is just trying to sort of show you the groupings. Okay, these values here are going to be somewhere the abdomen and bone in the chest x-ray. This would be the heart and the mediastinum. This would be the lung field. And this very, very dark area is the area of direct radiation where there wasn't any anatomy. Okay, so it tells you that this spike will not show when the entire IR is covered by anatomy. So, for example, in this chest x-ray, you can see that the minimum pixel values are plotted here. The maximum are plotted here. These values right here in this spike are not a part of the image anatomy, right? And it's drawing arrows. So if you look at the arrow that's drawn from this spike, it's pointing to this area right here. Is there any anatomy covering that area? No. So this spike represents these pixel values out here where there's nothing there's no anatomy there in front of the beam. Okay. So what this slide is saying is, in other words, on a typical abdomen on a good sized patient, okay, are we going to see this? No, because the 14 by 17, if that's the size IR we have, is pretty much going to be completely covered by anatomy, isn't it? Unless you have some really slim somebody, you know, where you don't have this extra stuff that's covering up the entire 14 inches in the width. You have a little slim person, then you might see it. But if it's you know, how most of us are going to take up the majority of the 14 by 17 with something like an abdomen. So again, the values that are available are plotted on X, and how many times we see each of those values is plotted on Y. And when we look at these peaks and valleys, like peak, valley, that represents the subject contrast in the image. Any questions so far about histogram? Okay. All right, exposure data recognition is also only related to, now, a histogram is, you get a histogram whether you use CR or DR. Okay, there's still a histogram that's created. However, image sampling is only with CR, and exposure data recognition is also with CR. So the PSP, the photostimulable phosphor plate, that's CR technology. That imaging plate records a wide range of X-ray exposures. If values at the very extreme high and low ends of the exposure range are used, the result would be an inaccurate histogram. To avoid this, exposure data recognition is applied. So what this is talking about is it is trying to recognize just those values of interest, okay, of the anatomy. So we don't want it, or it doesn't want to take into consideration that spike, for example, when it's creating the like the exposure indicator, or when it's doing the automatic rescaling. It wants to exclude values that are not a part of the actual anatomy. All right. So exposure data recognition, it wants to recognize that data that is valuable to us. What are we actually looking for? So what it's saying is it's going to exclude these very low exposure levels and these very high exposure levels, so that it gives us a more accurate histogram analysis and more accurate rescaling, automatic rescaling. So in this exposure data recognition, it's the process of distinguishing the brightness values that represent anatomic structures of interest. That's what I was just talking about. Values of interest. So if you see VOI, that stands for values of interest. That means what is the anatomical, what are the anatomical values that we're trying to see here, and exclude those that are outside the exposure field. So it's going to look for collimated edges. It's going to eliminate data that's outside that collimation, which often includes scatter. So that's a good thing. It tries to exclude those values. Information within the collimated area is the signal used for image data. So that is the good signal that we want it to use when it's calculating the exposure index or indicator, or when it is doing the automatic rescaling. Now, there's something called segmentation software that's used in CR to identify and count the number of views taken on a single PSP plate, so that each exposed area can be treated separately by the reader. So back in the day of film, we would use one 10 by 12. Let's say this is a 10 by 12. No, it's not quite. All right. But if we could get multiple images on one, how would that benefit us when we were talking about film? Why was that a benefit? How was that a good thing?
Well, it's expensive.
Yes.
Just use one.
Film was expensive, right? Chemistry, the chemicals in the processor was expensive. So if we could put multiple images on one piece of film, that saved the department money. So we were all about that. We did, you could do literally 4 images of the wrist on one piece of film. Okay. So when we transitioned to CR, we were still in that mindset, right? So we continue to do multiple images on one plate because it did reduce the wear and tear on the plate. Okay, the number of times that it had to go into the reader, right? So it still was a way to save. It was still a way to have less wear and tear on the equipment, on the plates themselves that were inside of the IRs. So we continued to put multiple images on one. That's what this is talking about. So what we would do is there were rules for that though, and you had to do that properly. And I believe I have that in here towards the end, where when it says it was looking for collimated edges, it wanted, when I say it, I'm talking about the when it's going into the processor and it's being sampled. It wanted to see collimated edges. It wanted symmetry, right? Because then it could say, okay, well, no, we're not including these values. Okay, yep, these values we're including. Again, nope, here's a collimated edge. I'm not going to include the values between the images. Does that make sense? So segmentation software was something that we could use. In other words, you would choose multi-view hand. And that way the software knew it was going to be looking for more than one image on that plate. So segmentation software was important to the processing of the image, the exposure indicator that was created, and the histogram analysis. It was very important. Of course, now we can't put multiples on, right? Because it's automatically processing that as we do it. So we can't do 2 images on one at one time. It's all single. So histogram analysis, meaning the analysis of those values that are plotted on that histogram, it is complex. But histogram analysis is what gives us the basis for automatic rescaling, which did we talk about that last week a little bit? I can't remember. I think we did. I'm getting it confused because I reviewed this with the seniors. So now, and I reviewed everything with the seniors. So now I'm getting confused. But so automatic rescaling is when, I don't think we have done that yet. Okay. It's when the values get reassigned so that the brightness appears correct on the image. The shape of the histogram stays fairly constant for each part exposed, meaning anatomy specific, meaning my chest histogram should look very similar to yours. And this is why it's important to choose the correct anatomic region on the menu before exposing the patient, so that the correct algorithm is used when it is processing. Raw data used to form the histogram are compared with a normal histogram of the same body part by the computer, and then image correction takes place at this time. So there's a couple of models. I used to really get into this a lot deeper, and I just really don't think it's necessary. So the main thing that I want you to know about histogram models are these two main types. A priori or priori is one, and neural is the other. The type that's used depends on the imaging requirements of the exam, meaning the anatomic contrast, collimation. It determines the regions of interest to be processed for optimal visibility of anatomic structures, looks for minimum and maximum pixel values. So let me just jump back here for a second. So what it's doing is it is looking for these minimum values and the maximum values of the values of interest, so that it excludes things like this spike, where we know that's not the anatomy, that had no anatomy over it. So it doesn't want to include those values when it's doing the histogram analysis. So basically, again, I just want you to know the names of them. I used to get into, because a priori has 3 different types, and neural is like considered a thinking model. So I think it was just more than you needed. Regardless of, yes.
Okay, when you keep saying when you pick it at the computer, you're not talking about APR, you're talking about when you select the study.
Right.
You're clicking, these are the exams. Okay.
Yes.
Sorry, I want to make sure I'm tracking.
Right. And so it, in some cases, like our equipment, when you choose the projection, that's why I always say, make sure you're on the correct projection over here before you go and do anything else. It would automatically pull up your KV and your mass. It's associated. Some rooms, the workstation is separate from the control panel. Now, the push and the move is to combine them like they are in our system. But some of the rooms, have you noticed that it's 2 separate things? Like a lot of the ortho places, you have the control panel separate, and then you have the workstation, right? So good question. Yeah, when I say when I'm talking about the algorithm that's being chosen based upon the projection you're choosing, that is within the workstation. Like what patient you're choosing, and if you're choosing PA chest, lateral chest, PA hand, AP foot, whatever. That's where when you select that, you're selecting the algorithm and the lookup table that's going to be used to process that image. Good question. So regardless of the type of model that's used, if those captured values, meaning the values that the computer is looking at for the data set of our particular image that we're doing, when they don't match up with the standardized values, then automatic rescaling occurs. So when we talk about the lookup table, LUT, it's a table of data that converts input gray level values to desired output values for the displayed image. So it's it's like a reference. It's like, okay, these are the ideal set of values for a chest x-ray. And if the data set that we give it, meaning the information that we give it based upon the exposure factors that we use for that particular image. Let's say that we underexposed the image. We didn't use enough mass. Okay, so the data set that we give it is not going to match up with the ideal, right? Because we're underexposed. So what it's going to do, it's going to change all the pixel values to a new gray value so that it will have the appropriate image brightness when it's displayed. So even though maybe, or let's say the opposite, let's say we overexpose the patient. Okay, so our values are not, again, going to match up with the ideal set of values that it's comparing to. So everywhere that it's off, it's going to be reassigning values so that when it is displayed, it looks like we used exactly what we should have used. That's what automatic rescaling is. I'm so sorry. I'm so junky today. So when we talk about the lookup table, those values can actually be plotted, okay? Plotting the original values on the horizontal axis. So this would be our original pixel values, our original data set, the information that we're giving the computer, okay? And plotting the new values with the same range on the vertical axis. So, excuse me, it's taking the input. So when we say the input gray level values, it's taking those input gray level values that we give it, and it's changing them to the desired output values so that it displays appropriately. And that's done with actually a graph, okay? When we do the ImageJ activity today, or this week in lab, we're going to see how does changing the slope of this line, how does that change the image? How does changing the shift of it right to left, how does that change the image? So we're going to actually do this with the ImageJ, and I think that this part of it will make more sense once we do that. But this statement right here says contrast can be increased or decreased by changing the slope of the graph. So it's talking about the slope of this. So to change contrast, we change the slope of this graph. To change brightness, the slope doesn't change, we just shift the line left to right. And so that's what we're going to do in lab this week. Excuse me. Original values assigned or changed for the processed image, and then it appears different. So it will appear as if we use the appropriate exposure factors. Now remember, there's limits to everything, right? So if we have overexposed the patient to the point of saturation, there's no amount of automatic rescaling that's going to correct it. If we have underexposed the patient to where there is noise in the image, excuse me, then there is nothing that we can do to get rid of that noise except do what? Repeat it. Do it over. Right? Okay. So applying changes to the image. This is just a visual to help you understand sort of what is happening with the lookup table or when we post-process the image and change the contrast. So if we had, let's say this was our image here, and all of these pixels were assigned a value of 40, and these pixels right here in the middle were assigned a value of 30, then we would consider that to be pretty low contrast, right? Why would we say that would be low contrast?
They're too close to each other.
They're very close together. The pixel values are very close together. The shades that represent those pixel values are very close together. So once a lookup table has been applied, then everywhere there was a 40, there is now what? A 90. And everywhere there was a 30, there's now a 10. So do you see how this is going to display as higher contrast than this one? Because there's greater difference between the pixel values and the shade that is assigned to it. Make sense? Okay. So here we go. So I already sort of covered some of this. Automatic rescaling is when the computer compares the obtained image histogram, so the data set that we give it, with the selected lookup table, the ideal values for that image, and it reassigns pixel values to bring it in line with the ideal. So again, if we're overexposed, it's going to rescale the image lighter. If we're underexposed, it's going to rescale it darker. It's going to attempt to. And so we get images that have uniform display brightness over a wide exposure range. So the live statement is what I just said. There are extremes where it's gonna fail. It can't fix it if you've used way too much or way too little. Let's see. Automatic rescaling is no substitute for appropriate technical factors. This last statement, danger exists of using higher than necessary mask values because doses will creep up over time. What this is talking about is as you begin to get more experience in clinic and with your images and the way your image, excuse me, your images look, you will realize that you would rather have overexposure as far as image quality than under, right? Because the computer can fix more overexposure than it can under, okay? So what can happen is you say, all right, let's say you use 2 on a foot, okay? And maybe the next foot you say, gosh, did I use 2? Or what did I use? Okay, well, I don't want noise in it, so I'm just gonna go ahead and use 3, okay? And if you're not paying attention to your exposure indicators, then over time, you can just gradually increase your base mask values for projections because you don't want to get noise in your image. It's better for image quality if it's overexposed. It's worse for patient dose, though, right? So what dose creep is talking about is that just slowly over time, mask values can tend to creep up a little bit because we do not want to get noise in our image. So we're like, well, I'm just going to use a little bit more just because I want to make sure I don't get noise in my image. So that can happen. And then all of a sudden now your base for a foot is 4 instead of 2. But your image quality still looks what? Great. It looks good because it can correct using 4, you know, but what it can't correct for so much is the noise. So you just want to be mindful of that. You want to pay attention to your exposure indicators. You want to try to stay, you know, as close to the target as you possibly can. This is just showing you that there can be 3 different exposures of this knee, and they're going to all project like this. So even when we underexpose a bit, this would be considered ideal, or overexpose a bit, they all get displayed like this. That's what automatic rescaling does for us, which is a good thing, right? It's great. But it can also make us lazy and sloppy, right? We don't want to be lazy and sloppy. So some histogram analysis errors that can occur that can cause the exposure indicator to be inaccurate. If the incorrect exposure factors were selected to begin with, say you just screwed up and you used the wrong thing. If you used the wrong lookup table, so you accidentally, the patient was for multiple things and you shot their chest under a hand. If your centering was poor, meaning let's say you included a lot of the abdomen with the chest, or your collimation was poor, if you had poor beam alignment, if you get a low intensity radiation response, meaning you didn't use enough, or if you have poor scatter control, all of these things can cause you to get a histogram analysis error, which can then make the brightness not display correctly, and which can what we call corrupt your exposure indicator. So if you have any of these things happen, then generally your exposure indicator is not going to be accurate and your brightness is not going to display correctly. So this just goes with what we were saying earlier. Use what you really need to use. Don't overexpose, don't underexpose. Keep your KVP optimal so that the part is well penetrated. Correct lookup tables have to be chosen by selecting the body part or projection from the workstation menu. I know this is like the 10th time I've said that, but I cannot tell you how important it is. It does matter. Not only for, so let's look at the rest of this and then I'll tell you the last thing that I was going to say there. If the wrong one is selected, the computer will try to align the values with the incorrect lookup table and you will get a rescaling error. So what's going to happen is you did a chest, but it's using the lookup table values for the hand, and it's trying to bring these values in line with these, and it doesn't make sense. So it's not going to display, the brightness is not going to display correctly, and the exposure indicator is not going to be accurate. And the other reason that it's important is that that needs to be corrected before it's sent to PACS. Why do you think it's important that the chest x-ray that you did be under the chest x-ray, aside from the fact that it messes with the processing parameters?
I mean, if the patient were to come back and get another x-ray under a different thing, wouldn't you need it labeled correctly when it gets sent to the other people looking at it in the system?
That's part of it.
Is it gonna be saved under hand? Like,
Yeah, so billing, that's going to be a huge problem. If those things do not jihad, right? You have a chest x-ray, but it's coming up in the computer as it was done as a hand. Remember that DICOM header that we talked, section 3? I forgot to show y'all that last week. But all of that needs to match for billing purposes, for reporting purposes, insurance, all that stuff. It needs to match. So if you do it under the wrong thing, typically you can correct it before you send it to PACS. You can edit what you did and fix it and put it under the correct projection. If you can't, then your PACS administrator should be able to. Yes.
Okay, you can finish what you're saying.
No, go ahead.
So at Memorial, they told me, so I see the difference between like a wrist and a chest. But at Memorial, they were telling me if you put it, you do a PA wrist, you can do all 4 projections under your PA wrist. Is that as big of a problem or no? Was my tech wrong?
Well,
Are you not mainly talking?
what I would say is, why would they have oblique and lateral if you weren't supposed to use it? That's my question. Because there's a difference between, now not necessarily a wrist, because there's not a huge difference.
Right.
But there's a difference between an AP foot and a lateral foot, or a PA hand and a lateral hand, right? So I would say it's not as big of a deal as far as the PAC stuff goes, because it's still gonna say wrist.
Mhm.
So that part of it's fine. But why wouldn't you just choose lateral?
The
I don't
context was, it was, I think it was arm, I think it was an arm, and the patient was not this like normal size.
understand.
So if I shot the shoulder in her arm in both under AP, then I didn't have to change my technique. And the technique was already set for me. I think that was their reasoning. And it works the same for arm, wrist, femur, things like that. Doesn't work as well for like an L spine, but
Well, I will say this. Do what they tell you to do. Because ultimately it's on them,
okay,
not you.
okay.
I'm
But
gonna
I
do
started
it
working.
the way it's supposed to be
Okay.
done. If I have to push a couple buttons to change the technique, what's the big deal? That's just me.
Mhm.
I just think that they wouldn't have. What was he thinking? They wouldn't have them listed individually
Mhm.
if they didn't want you to use them. Just like they wouldn't have 2 grids if it didn't matter. So I'm not saying they're doing anything
Right.
wrong, especially since it's within, all of the projections are under the wrist. That's the biggest thing. You don't want to do even hand to wrist. you don't want to do hand and it say wrist because again, they're two separate things and it can affect billing. It can affect a lot of different things, insurance wise and all that. So I see what they're saying, and it's probably not a big deal, PA to oblique to lateral wrist, as long as it's still under the heading of wrist.
Mhm.
So, but I don't know. I'm a rule follower. I can't help it. I just am. I want to do things like it's supposed to be done. So, anyway, it's a good question though. I hope I answered it.
No, you did.
Never, ever tell them that I said they were doing something wrong. Because I have to go out there, right? And when I walk in the door, they act like I'm the police anyway. So, you just, well, my soapbox, just, be the tech that you would want your loved one to have.
Moral of the story, don't be lazy.
I mean, it's not that hard. Don't be lazy. Don't be sloppy.
My initial
Don't be
question
just good enough.
was about the lookup table, and does it really affect it that much?
No, it would not from that perspective. Now, from an AP to a lateral lumbar, yeah, it's gonna change. It's gonna change the lookup table that's used. With the wrist, not that big a deal because there's not that big of a difference in the part. But anyway, just
Sorry, I did not mean to
No.
derail you.
No, because we're just dealing with some things out in clinic right now that just really breaks my heart. Because I've been in this field for a long time and I don't like to see sloppy and lazy and just good enough. And I'm just getting a paycheck. I mean, it needs to mean something. So anyway, on to the next, right? Right, sure I'm staying on track here. So positioning and centering is really important. Especially we know when using the AEC. If your centering is not accurate, then it can cause weird things to happen, like displaying wrong or your exposure indicator not being accurate. So here's where we're going to get into some of the specifics. So collimation is important. You don't want background information included in the values of interest. It widens the histogram, meaning it's including a lot more values than it needs to. You can get low contrast. You can get the incorrect exposure indicator. So things like this, you want to see a 4-border collimation. You wouldn't want the whole entire plate to be used in that. And the thing with this picture as well, even though this is film, okay, or it may not be film. I mean, these were used with film. See these markers? They had to leave the collimation open enough to include that this was a female and this is a left. But did they really need to? I mean, they can sit. This too goes back to sometimes the radiologists are just spoiled rotten, right? They can't look down there at the information and see it's a female. It has to be plastered across the top of the image. What I'm saying is sometimes things like this gigantic left marker and this big old female marker can skew the histogram analysis as well because it's including these things in it that are not really part of the anatomy of the patient. So this is where I was talking about when we were using CR. If you were going to use a single exposure on the plate, that was ideal. It should be centered to the plate and 4 collimated borders was ideal. In other words, it really wanted to see a 4-sided collimation on a single projection done on a CR. If you were going to do it otherwise, it was still okay if there were 3 margins, if there's no margin between one edge and the exposure field. So like in other words, there's not really an edge here. So these 3 would still, the histogram analysis should still be accurate. This one, again, it should still be accurate, even though we didn't collimate, top to bottom here. This still would be accurate because it would be reading along and saying, okay, no, not including this. Oh, there's a collimated edge. It would include all of these values as it was reading and then say, nope, there's another collimated edge. Don't include these values. So that was still okay. What wasn't okay was when there was only one or two margins and the exposure field was not centered. So let's say you had it something like this. This would be inappropriate. This would not work great either. When might you encounter something that looked like this? Y'all have done two different things in Yolanda's lab where you might get something that looks like this, where only the bottom part of the IR is being exposed. What?
I'm the queen of not aligning the IR with
But this is one where it's easy to do because of the way you have to set up.
Cross table, lateral spine, cervical spine, or anything.
More so hip, right? Cross table hip. Think about it. How you're exposing the bottom part of it, or axillary shoulder, possibly the spine where you're just getting the bottom part. So this could cause an issue. Now, so for example, this is a cross table or a trauma hip. It says histogram analysis is confused by the scatter outside the exposure field, meaning this scatter here is confusing it. The exposure field is not recognized because we don't meet those criteria, like these criteria, either being in the center or having three margins. We don't have that here. So it widens the histogram, which means when I say widens the histogram, it means that all of these values out here are being included. And that's bad because those should not be included. And that's why this thing is being displayed really dark. And if we saw an exposure indicator, it would probably not be accurate. There's not really, okay, so the possible solutions: support or build up the part to place closer to the center of the receptor, collimate to show borders, add lead to the bottom. This would be difficult, but with simulated collimated border. So probably the better or the easiest thing to do would be to build the patient up a bit so that you can get that border on the bottom. This add lead to the bottom thing, can you imagine trying to add some lead to the bottom on a trauma hip, as hard as those are already? There's no way. So we don't have this issue with DR like we did with CR. So with DR, you're not going to notice it as much. You're not going to notice this particular problem. This is only with CR. Other beam alignment precautions. When might you do something like this? When might you turn it and do like this across? Yeah, tib fib, femur, possibly if you're doing it tabletop and you're just trying to include from the head to the knee. So this one would be fine, even though the collimated borders go outside of the cassette a little bit. That would be okay. This one would be okay. This would not. This would not display properly, and the exposure indicator would not be accurate. So here you can see how this is correct alignment. We have from corner to corner. Here, see how this is not symmetrical. It's not corner to corner. So do you see how dark this is displaying there? If we had a exposure indicator, you would see. So this kid had a really bad femur fracture. Do y'all see that? So here's where it's healed, and then here's the little knee, and then the tib fib. So that image is actually rotated sort of upside down. With CR, another thing that we had issues with is if we didn't use at least 30% of the length of the IR. So you can see that if you did a navicular on an 8x10, it would display properly. You had it right in the middle. There's 4 collimated borders. Here, if the navicular was done on a 10x12, this is how it would display, and you'd think, oh my gosh, I got to do this over. But you really didn't. You just have to brighten it up. You'd have to physically change the brightness of the image for it to show up. And the reason is because it didn't cover at least 30% of the IR. So it couldn't, the histogram analysis was not accurate. So here are the multiple fields protocols. Symmetry is key. Collimated margins are essential. No overlap of the fields. So you needed to have a margin between the field and the edge of the receptor. Adjust the technical factors for each projection as needed. So in other words, if you were doing, say, a PA hand and a lateral hand on the same cassette, you would still need to change your technique from PA to lateral to compensate for that change in thickness. So all of these would be ideal. See how they're symmetrical? There's 4 borders here. There's edges between all of these, so it can determine where the actual values of interest are. So all of these would be acceptable. All of these would not. So you say, well, why would you do that? Well, you might not mean to, right? You're doing a patient and they're not holding still and you're just trying to make sure that you're not missing something. So none of these, if you did any of these alignments on multi-field or even a single like this, it's not going to display appropriately and your exposure indicator is going to be wrong. Multiple fields, correct example. See how you have nice symmetrical borders here and both images display accurately. Here are some examples of not doing it appropriately. See how there's no edge between the border of the cassette and the collimated field. So why do you think that all of these are displaying, especially this one, super dark? What's the thought process behind that? Why is the computer displaying these super dark like that?
Because it's reading the white, there is a lot of.
Yes, it's taken into consideration all of these very bright values, right? When it's doing the histogram analysis. And so the computer thinks, gosh, they way underexposed this part. So what is it doing? Darkening it up, right? So because it couldn't determine where the values of interest are really, it's just taking the whole plate into consideration. And it's using all these values out here as well. So it thinks you way underexposed it when you really didn't. And it's darkening up all of the images. It's trying to fix it. So that's why it's just super important that you, well, again, I really wish we could stop having to teach all this because CR is going away, but we still have to cover it. So. But nowadays, I don't think they do multiples on one, do they? They do everything single, which is the safest way. So now let's talk about scatter or background radiation. We talked a little bit about this last week, how important it was when we were doing CR that you didn't just leave CR cassettes laying around and you didn't leave them all weekend without being used, without erasing them. There's a very low response threshold. So your CR cassettes were very sensitive to scatter and to background. And this is why you must erase plates every 48 hours at least. 24 is actually recommended and use a grid as required. So I want you to highlight this right here because this is saying that it's about 60 to 80 microns per day. Microroentgens. About 2 days background exposure is enough to get a response. So that's why it was so important that like you didn't take all 4 of your cassettes in with you when you were doing a multiple views on a patient. You left them behind the control panel, behind the LED. You wouldn't want to just sit them on the table because it's going to pick up that scatter and that's going to be in the background of your image. It's the same thing with background radiation, just them sitting around, accumulated background radiation on them. So you didn't want that happening. That's why you wanted to erase them if you weren't sure they had been used. this is what it might look like, the background exposure just after 72 hours. Do you want that in the background of your image? No. So that was why it was important. Post-processing techniques. The digital image may be manipulated in a variety of ways. We know that. We can rotate it around, we can flip it, we can adjust contrast, brightness, all these different things. However, the manipulated image should not be saved and sent to the radiologist, as this will limit his or her ability to further post-process the image and data will be lost. In other words, it's fine for you to mess around with it, but don't save those changes and send that to the radiologist, because then that limits their ability to manipulate the image. So, if you make a change to the brightness or the contrast, then you should find out or be aware, is that going to automatically save? Do I need to undo it? Because most of your equipment has either a total undo, say, oh, no, click that, and let's just undo everything we did post-processing, and it sets it back to you the original way it came up when you first saw it. Or some of your software allows you to keep the original, make adjustments, and then save those as a totally separate image. And that's okay. But you don't want to completely get rid of your original information for your image. So it's very software dependent as to whether or not it does that. And I know that you probably see techs do that all the time. Make changes to the brightness and contrast of the image and send it. Is that best practice? No, it's not. The radiologist can do what they need to do to it once it comes across. And I understand that they're trying to pretty up the image. I get that. You want the image to look the best it can, but if you do that and you're getting rid of the original data, then you are limiting what the radiologist can then do to the image when you send it. So subtraction we talked about already with fluoro, but it's a technique that can remove superimposed structures. It basically subtracts out the brightness values that it doesn't want to be a part of the image. So for example, you can see that on the left, all of the bony structures have been subtracted out, those values, and on the right, the soft tissue structures have been subtracted out. So pretty, uh-oh, did it spill?
A little bit. Okay.
Image processing parameters. So the initial digital image appears linear when graphed because all the shades of gray are visible. So that's the raw data. So have any of y'all ever noticed, like, portables? When the image is first coming up, it's very what? Super gray, right? And you think, God, that looks terrible. And then all of a sudden, ta-da, right? And it just displays and it's beautiful. That's because all that initial data that's coming across, it's very low contrast, because it's trying to display all the shades that are available, and then the lookup table happens and the corrections and the automatic rescaling happens, and then the display brightness looks really pretty for whatever projection you're doing. If all of those shades were left in the image, the contrast would be too low. You wouldn't really be able to see much. So there's ways that we can manipulate even post-processing. The image contrast, we've been saying this since pretty much first semester. Image contrast now is controlled by the computer, right? Changing the steepness of that graph is what changes contrast. No amount of adjustment that can take the place of proper technical factor selection. That still needs to be something that you choose correctly when you're doing the projection. This is an example of contrast manipulation. Which image, you should be able to tell it there. It looks a little better on my screen. Which one has higher display contrast, left or right? Huh?
Right.
The right one, because it's displaying higher contrast because the white's whiter, the darks are darker, right? That's just one example of how image contrast can be manipulated. Now, these next few slides are some additional tools that are usually available in the software. Edge enhancement is a very elaborate software function. It increases contrast along the edge in the image. Do y'all see the difference? So from here to here, you see how the edge contrast is increased. This is also known as high pass filtering. Something you just got to memorize. If this is overused, then it can cause what looks like a halo effect. So let's see. Oh shoot, I used to have a picture in there. I took it out. No, here it is. Okay. So edge enhancement, an actual example of projection. Here we have a hand, and y'all see how the edge enhancement has been used, and now along the edges of the bones is a lot brighter. Halo artifact is this artifact that we're seeing right here along the edge of this prosthesis. See, we don't see that in this image. So you can over manipulate digital images to where you're degrading the quality of the image. So less is more most of the time. This could look like something that's really not there. This could look like some kind of pathology that's really not there. So that's why I'm saying limit the amount of manipulation that you do to your images. Inversion, you may have seen this used in clinic. I used to like to invert the image if I was trying to tell if I had all of the rib margin on there, or trying to tell if I had rib margin on there to make sure that I had the lungs on there. Also, a lot of times you could see feeding tube placements a little bit better. So this is just reverses the grayscale from the original. It's also known as black-white reversal. So everywhere that typically normally is very bright is now dark, and everything that was dark is now bright. Smoothing is another software function that suppresses image noise. It's known as low pass filtering. It's supposed to help reduce graininess and contrast, but the edge is still degraded. So I would be very careful about using smoothing software. If it looks noisy, just do it over. It's better for the quality of the image, and you don't want to send images that you can see noise in, because then it'll look even worse to the radiologist. So again, this is the original. You can sort of see how it looks noisy. This is just smoothing out. To me, this looks worse. I don't like it. So I would say limit your smoothing. Equalization is a pretty cool thing. It's also a post-processing function that when underexposed areas can be made darker and overexposed areas can be made lighter. It's generally just expanding this histogram to fill the entire grayscale. So it's taking this histogram and sort of expanding it into the entire grayscale. Where this might be important is something like an oblique C-spine, where this upper part of the C-spine and the lower part of the C-spine are not well visualized. That equalization just sort of allows you to be able to see the whole C-spine equally. So that's pretty neat. Image stitching is used for anatomy or areas of interest that are too large to fit on one cassette. The images can be stitched together, so things like scoliosis series, leg length or mechanical axis studies. There's generally special cassette holders that are used, or special systems that are used for these projections. It eliminates the need for very large cassettes previously used in film screen radiography. Oh my gosh, we used to have to use these things. They were this tall and they had grids in them, so they were heavy, right? And we'd have to put 3 pieces of film in there and tape them together at the end so they could hang them up. That's how we did it. We stitched them ourselves by taping them together. So now you don't have to do that. Most places have software that will stitch them together. This is a very severe scoliosis here. So it takes these 3 separate images and stitches them all into one so that they can do their measurements and measure the angles and all that kind of stuff to figure out how best to help those patients, whether it be surgically or the brace or something. Now, this is always well, that's not what they do out there. Well, I know, but again, we're teaching you best practice. Okay, what is best to do? So unexposed borders around the collimation edges allow excess light to enter the eye. It can cause, again, what's called veil glare. And that's just like a distraction. It's like when you've been in a dark room and you go outside, or you're in the dark room when I flip these lights on. It's a lot of light that's flooding your eye at one time. Black masking or shuttering or electronic masking prevents that. So it's covering up with black these very bright areas that would have been flooding your eye with light. So the bottom line is, legally, and I'm just telling you legally, you should not black mask or black border off anything that is not collimated off. Does that make sense? So you should not black out anything anatomy related, because the radiologist is still responsible for that information if it was on the original image that you did. So just because you didn't collimate properly does not give you the right to black out what you didn't collimate off, because that information is part of that image. And if the patient had something there that could have been diagnosed, ultimately the radiologist is still responsible for that information. So I understand, again, trying to pretty up the image, trying to make it look better, but this should not be done. And I know that it is. I know it is. But I'm just telling you, legally, it shouldn't. Now, if you do something and you didn't collimate and there's no anatomy at all out there, that's different. It's okay to do that. But if if you do a little old 80-pound lady's chest x-ray crosswise for whatever reason, that should not happen when the person's this wide. You shouldn't do her crosswise. And you got both arms and 3 inches on either side of the arms, and you didn't collimate. Then legally, you could black border off to the edge of the humerus, and that's it. You should not come in any further than that if you didn't collimate it on the original image. That makes sense? Okay.
Okay, follow up.
Yes.
You said the radiologist is responsible. What if it's an ortho site and it's not being read by a radiologist?
The doctor's responsible.
Okay.
Whoever's looking at that image.
Okay.
So best thing to do is just suck it up. Send it. You know? It happens, I would say, mainly on children, where maybe you didn't collimate well, you left it open way too far, and you included way too much. Say that the kid was for an abdomen, and you pretty much included the chest with the abdomen. That's where we're talking about. Don't black out half of the chest. You already did it. You know, it's already been done. Let somebody look at it to make sure that there's not something that needed to be read there. Any other questions? Oh, we are out of time. We will finish this in lab. How far?